Now, see, this is the right articulated foot. Okay. Now, this is the calcaneus, the talus, navicular, cuboid, and the three cuneiforms. When you go to the practical dissection hall, take the articulated foot and it will be জলের মতো সহজ হয়ে যাবে. You put it in your head and definitely if you are asked during Viva that the tray in the lower limb bones are there. So tibia, fibula, articulated leg, articulated your foot, all are there. If you remember this, you pick up the articulated foot. At the most, the muscles are there and mostly tendons are passing. That's one. Now the three cuneiforms, I'll take, there's no space. This is N for navicular, C for cuboid, T for talus, C for calcaneus. Okay. Three sets of veins: superficial, deep, and perforating. Superficial, deep, and perforating. Superficial vein lies in the superficial plane. Great saphenous and small saphenous vein represent preaxial and postaxial veins of developing limb bud. Now, the embryology of it, the preaxial and postaxial veins of the developing limb bud. Okay. Now you see lies in the superficial plane. You will be dissecting or seeing the body, dissected body. You will see the veins over here, and also you can see it in the body, in your personal living body. But when you dissect, you will see the your superficial vein represent preaxial and postaxial veins of the developing limb bud. Now deep vein. Now, deep vein surrounded by powerful muscles enclosed in deep fascia, accompanying arteries and include tibial, peroneal, popliteal, femoral. You just try to figure out and the component, because in this many questions can come. What is the perforators? What is perforating artery? What is perforating? And also your varicose veins, and how suddenly if it is injured, then they are having alternative pathways. Okay, and surrounded by powerful muscles enclosed in deep fascia, accompanying arteries and including tibial, peroneal and popliteal, femoral. Below knee arranged as pairs of vena comitans, above knee from single major vein. And why it is in the deep muscle that it pumps the muscle, the soleus. Soleus is also known as the heart of the lower limb, because it pumps and this thing, the blood goes up. And this is one thing. Below knee arranged as pairs of venae comitans. Above knee from a single major vein. They form a single major vein. Now, perforating vein. Now, communicates superficial with deep veins by piercing deep fascia and following intramuscular septa. It is following the intramuscular. When you see, best is that you take a transverse section of different parts of the leg. You see in your books, you will see how the compartments are made, and also the vessels passing through. And now valve at each end and permits blood flow from superficial to deep veins and not in opposite direction. Veins from muscles draining into deep veins are valved except those in the soleus, where they are arranged in as venous sinuses. Venous sinuses. So the whole thing is pumping. You see a runner, or when you are dancing or running and at high speed or low speed, but you don't get fatigued. And so if there is any vascular disorders, then you get fatigue. If you say in your walking a distance, suddenly muscles get fatigued and you have to sit down. You are going on a bicycle, then again after a distance of 1 kilometer, you get fatigued. And your now this is one thing, with valves at each end and permit blood flow from superficial to deep veins and not in the opposite direction. Now you see perforators of the in lower limb can be a short question. short question. It can, with other components, it can be a short question of 4 marks or it can be 8 marks. Now see the superficial circumflex iliac, the medial vein of the thigh, femoral vein, this thick femoral vein here of the thigh, long saphenous vein, popliteal vein, anterior vein of the leg, gastrocnemius or perforator void. Now posterior vein, arch of the vein, lower leg perforators of cocket. Now 3, 2, 1, 3, 2, 1, and ankle perforators may or Custer. This is the name of the anatomist who dissected out and found, they were first to see this. Now you can see, now perforating vein, venous blood of foot flows from deep veins in sole to superficial veins on dorsum of the foot. In leg and thigh, venous blood flows from superficial to deep veins directed by valves of perforators. 4 perforators are present in the lower limb. You have to be knowing this anatomy because of being judgmental in amputation or any vascular diseases. Any vascular disease at one level, the pathology is. Now you see here, see these are the venia and the perforators, the saphenous vein, anterior tributary of the saphenous vein, the posterior medial perforator here, again proximal and great saphenous vein here, and the dorsum of the foot. Now, it is a thing that at times you might need like you want to give an IV, it's 2 places or 3 places. Then in the lower limb, you can see you try a tourniquet, you can see the vein. You today go and try a tourniquet and see, it will be, you can put an IV drip. Okay, especially you have to know the anatomy. If you are in duty in NICU, that is neonats, babies, there you have to give it in the scalp. It can be known as scalp vein set. Now you can give it in the leg. And if I told you the other day that that if you want to tap blood in a baby or just delivered, there are conditions that you need to put an IV drip, also take blood from this thing. So if you see your is a male child. So more laterally is the artery placed. Now the vein is medial. You palpate the pulsating artery and then you go bit medially and you just take a 5 ml or 2 ml syringe. 2 ml will be sufficient. because in the equipments for modern hematological practices are you need a small quantity. The micropipette is small, very small quantity. You get, say, it is in a state that you cannot give more than 0.5 ml blood. It is a desired value, you get 1 ml. So you tap, femoral tap. You tap, if you see don't pierce the pulsating vessel. You can medially and shoot, and then you tap. That can give you now position of perforators. Now I'll just run through, because you know these are, I told you at the beginning of the lecture that in lower limb you have abundant questions, numerous questions can be asked. And see, the positions of perforators, mid-hunter perforator, or it can be in MCQ. Okay. Now, mid-hunter's perforator connects great saphenous vein with the femoral vein in Hunter's adductor canal, adductor canal. And knee perforator connects great saphenous vein with posterior tibial vein just below the knee and close to the medial border of the tibia. One lateral ankle perforator communicates short saphenous vein with peroneal vein and situated junction of middle and lower third of leg. 3 medial ankle perforators connects great saphenous vein with posterior tibial vein and joins with one and another posterior arch vein. Upper at the junction of middle and lower third of tibia, lower situated below and behind medial malleolus, middle intervenes in the midway between them. Now the perforator veins are there. The superficial circumference here, lower leg, third perforator, coccus ankle perforators here. Now peripheral heart of calf pump that I told you. Now the peripheral heart, short note. গালে হাত দিয়ে বসে যাবেন, এই কি হলো heart peripherally, what's happening, what is the তো মাথা ঘোরাতে লাগলে কি রে, হ্যাঁ, you just remember that the basic thing is that the lower limbs, vessels, the circulation, whatever it is, the venous drainage and the arterial supply, it is dependent on the muscles of but heart has its own muscles. That is the most, what to say, it's a pounding beats of the heart that just go on contract. Okay, according to your activity. If you are running, your intention, or you are in some jhagda, ladai, and dekh lenge, in that time the heart beats fast. But in lower limbs, you are not knowing exactly what is happening. But you see any wound in the scalp, any wound in the face, any wound in the chest, any wound in the abdomen, any wound in the thigh, and also the leg and the foot. If it takes 10 days in the face, over here it will be 12 to 15 days to heal. If you go to lower, it takes some time. Now you go lower, it takes time. And also you have to know that the if it is an obese person or skin thinny person, that when to cut the stitches. Yes, many people are going to Bangalore for their some surgery. It might be gallbladder, it might be your some surgery in the leg, even in now they write discharge. They discharge in 3 days. They put up in the hotel, and 7th day they go in again for a revisit the hospital. They say, you cut the stitches in your place. আপনারা আপনাদের সেলাইগুলো আপনার জায়গায় কাটিয়ে নেবেন. But what happens actually when you they bring the paper to me, I see it, then I tell them that no, you don't, I won't be cutting it. Because the experience which I in my medical career I have gathered, I am not for cutting any suture in 7 days, 6 days, this thing. See, and LUCS sutures, mostly the on 7th day or 10th day surgeons, this thing. That can be for a thin and lean, but I would recommend 12 to 15 days. Now, in upright position, contraction of the calf muscles within deep fascia squeezes the blood upwards along deep veins. So that acts. That's why, see, in big hospitals, even in United States of America, the operation for 6 hours or 10 hours or 12 hours, the patient is lying in the bed, all these monitors and pipes and your pipeline, oxygen, everything is going in there. And patient is after anesthesia. When you go to the hospital, when you are doing your duty, it might be your personal clinic, it can be any government job, and this, you make it a practice. You make it a habit. Like I had my school principal, he used to smoke at least 100 cigarettes. He was an Irish brother, so all yellow, nicotine stain. You might be having some friends who are smoking. He just again take another bidi. It's a habit you cultivate. So whenever you are on your rounds, say after the operation, like you do one operation, the ward you go, again after say 5 operations, then you go, the attendant, it can be the nurse or it can be any ayah, or if at all, in my place, the patient's family members, they have to stay with the patient. Okay, now you just show, hey, pata bhaj karo, please hold your leg. And then just show, just a minute, seconds, you just show it, massage kore de, hey, emni kore de, pass firiye dile, abar pite thap 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 kore massage kore debe. In some cases what happens, babu ekটু তেল দিতে পারবো? Can I use some massage oil or any? হ্যাঁ পারবি, আজকে নয়, এখন কিছু করিস, অত তেল দিতে হবে না. Okay, now this actually helps in the circulation of blood, so there are no bed sores. That patient within 48 hours or 72 hours on pressure sores, in these places they have and bed sores. So the larger the hospital and the patient Sister is in the nursing station, 10 of them or 5 of them in blocks. They are seeing their mobile and talking, gossiping. And what else? Ultimately, there's a switch in near the head. Ring 2 or 0. Ring to call this nursing personnel to come from the nursing station to your patient's bed. Don't you must, and you just, when you go on your rounds, you just lift up. Just 1 second it takes to lift up, and everyone knows massage. Okay, now this is why I'm telling you that then it happens that you turn over, turn down. Now in upright position, contraction of calf muscles with deep fascia squeezes the blood upwards along deep veins. Competency of valves in perforating veins prevents reflux of blood into low pressure superficial veins during contraction of the calf muscle. Now, peripheral heart or calf pump, short note. It can be even 10, then 2, 5 small 2 marks questions. Other component of lower limb can come into it. So 4 to 10, 4 to 8 marks. Now, peripheral heart or calf pump, or you are answering very well in Viva. You have picked up your tibia. Then it can come. The longest vein of the body represents preaxial vein of lower limb, begins as a continuation of medial end of dorsal venous arch of the foot supplemented by medial marginal vein, passes upwards in front of tibial malleolus, medial border of tibia, occupies posterior medial aspect of knee joint and patella, medial side of the thigh to reach saphenous opening fossa ovalis, which lies below the lateral to pubic tubercle. Passes through the saphenous opening after piercing cribriform fascia and finally drains into the femoral vein after piercing femoral sheath. And this can be on your OSPI, that level. What is this vein? You have to put in. Okay. Yeah. You can never forget. If you are short of time, then you just draw some branches and all and draw a leg, like I just drew this. Please practice simple drawings, you just sketch. Now you see, you draw a level. Say if it is an 8 marks question, drawing level, the tributaries of saphenous vein. Now saphenous opening, see here, the femoral sheath, these limb nodes, this is the male body, that is this is spermatic cord here, this is inguinal ligament, reflected part. Now inguinal ligament, this is the inguinal ligament, this is the femoral sheath, genitofemoral nerve, and these long saphenous vein, tributaries are multiple. Now similarly here, structures accompanying great saphenous vein. Now in thigh, few branches of medial femoral cutaneous nerve. At knee, saphenous branches of descending genicular artery. In leg and foot, saphenous nerve, the saphenous nerve is posterior to the vein at the knee, but in front of the vein at the ankle. When you dissect the body or the prosected body is shown to you, you please take your dissector and try to correlate. We have to be now examination oriented, focus, I told you, on things that is tributaries of great saphenous vein just below knee. Posterior arch vein collects blood from posterior medial aspect of calf and consists of series of venous arcades connecting three medial ankle perforating veins. Anterior leg veins extend diagonally across shin to join the great saphenous vein. A few veins from calf which communicate with small saphenous vein. Now, tributaries of the great saphenous vein in the thigh. Anterior lateral vein commences from its venous plexus on lower part of the front of the thigh, crosses the apex of the femoral triangle and joins the great saphenous vein in the upper part of the thigh. See, it has been the total, I told you in the initial stage of my lecture, that the lower limb is in compartments, in part by part by part. Then it becomes easy for you. Okay. Now, the posterior medial vein called accessory vein drains the posterior medial aspect of the thigh and joins with great saphenous vein. Sometimes it communicates below with the small saphenous vein. Now, tributaries of the great saphenous vein just before piercing the cubiform fascia. When you see the ये femoral triangle হয়ে গেছে হ্যাঁ ঠিক আছে okay just before piercing cubiform fascia superficial epigastric drain into the lower part of the abdominal wall below umbilicus here the lower part okay of the anterior of the abdominal wall. Now superficial circumflex iliac drain blood from lower part of the abdominal wall below umbilicus. Superficial external pudendal drains part of the scrotum and receives blood from the superficial dorsal vein of pedis, accompanying corresponding branches of femoral artery. Tributaries of the great saphenous vein, thoracoepigastric vein runs along anterolateral wall of trunk and occasionally connects superficial epigastric vein with lateral thoracic vein, establishes a communication between femoral and axillary veins. Deep to saphenous opening, deep external pudendal vein passes deep to spermatic cord after draining from anterior part of the perineum and finally terminates into great saphenous vein before latter opens into femoral vein. Now, valves in great saphenous vein. See, these are all small questions, compartment wise. You see, the 10 to 12 valves are present in great saphenous vein, out of which one valve lies just before it pierces cubiform fascia and terminal valve is located at its junction with the femoral vein. Saphenofemoral valve. In 80% of people, external iliac vein presents a valve which protects saphenofemoral junction against high pressure. Remaining 20% possesses no such valve and prone to varicose vein communicating from saphenofemoral junction extending gradually downwards. This is important, saphenofemoral vein. Now, the remaining 20% possesses no such valve and prone to varicose vein commencing from saphenofemoral junction and extending gradually downwards. Veins draining into the inferior vena cava. See, common iliac vein, internal iliac vein, external iliac vein, inguinal ligament and femoral vein, great saphenous vein, superficial. This is the anterior view. This is the popliteal vein, small saphenous vein, fibular vein, anterior tibial vein, dorsalis pedis vein, dorsalis varus arch, dorsalis metatarsal veins. And by vein, the main basic concept of the blood supply, your artery will supply blood, oxygenated blood, and the vein will supply your specific drain the drainage of the vein to the heart. Naturally, these are the it's having the similar Now, short saphenous vein begins below and behind lateral malleolus as continuation of lateral end of dorsal venous arch, supplemented by lateral marginal vein of foot, ascends along lateral edge of the calcaneus, and it is accompanied by sural nerve on lateral side. You will definitely find all this in your dead body, not your dead body, the body that is placed in the dissecting hall, or not my dead body. I'd want to live. I want to live for another 20 years. Tagore used to say, Modite chahina kobu ei sundar bhubone. I don't want to die. I want to live. So রবীন্দ্রনাথও তাই বলতো আর কি, তো তারই কোট আমি তোমাকে করলাম, তোমাদের জানালাম. Anyway, now ascends along the lateral edge of tender sural nerve, runs along the leg, back of the leg, pierces deep fascia, undergoes subfascial course between two heads of gastrocnemius until it reaches the middle of the popliteal space, where it terminates in popliteal vein. Posterior femoral cutis now accompanies the upper part of the vein. Now, when you have any pathology of Baker's cyst or your popliteal cyst in the popliteal fossa, then you have to make a lazy S incision, open, dissect out. You can see the vein, the artery pulsating. Out of that, you take out and dissect gently, and you take out the cyst. So, it is important. Now, you see, short saphenous vein, variability in termination. Now, in the short saphenous vein, sometimes joins with the great saphenous vein, the upper third of the thigh, either directly or through accessory saphenous vein. May bifurcate or joining great saphenous vein and other endings in popliteal or deep posterior veins of the thigh. Occasionally fails to reach knee and ends in great saphenous vein or deep veins of the leg, provided with 7 to 13 valves. Now, this is important because of its tributaries where it is opening and all, and 7 to 12 your valves are there. Clinical applied, see, this is a clinical and applied varicose vein, varicose ulcer, aortico-coronary bypass operation, venesection of the saphenous vein, Tendelbach's operation, stripping of varicose veins. These are all the procedures. Now, varicose vein, superficial veins of the lower limb are often dilated and tortuous and becomes varicose. Over the area of varicosity, the skin becomes pigmented and suffers from lack of nutrition and causes varicose ulcer, which bleeds profusely, causes thrombosis of deep veins, persistent elevation of intra-abdominal pressure due to abdominal tumors or multiple pregnancies, incompetency of valves in perforating veins or superficial veins or both. Now, the policeman or the army personnel who are standing like this, and also the traffic police. But traffic police moves. There was a traffic police in Delhi, and his duty was in the your parliament and your president's house and all that. That's multiple roads of meeting. So he used to dance actually and shows the signs. I think he knew the anatomy of the venous system of the lower limb. So he wanted to exercise and then so that he doesn't get an your varicosity. But here, now this is the before operation and after operation. Over the area of varicosity, the skin becomes pigmented and suffers from lack of nutrition and causes varicose ulcer, which bleeds profusely. Okay. Anyone with a lady who comes with a varicose vein, she shows you, don't recommend surgery. You have to like the bed end, the leg end of the bed. You put 2 bricks. So it will be this. Nah, I mean, balish nobo, pash balish nobo, all this. Eh? So the side pillow, which many people have a habit of having a side pillow. So that is a different thing because pillows and everything, where it flies off, God knows. When you are sleeping, you try to, you say your husband and wife are sleeping, one blanket. Suddenly you are in having 2 pillows near your leg and all. That moves off where? But the elevation of the foot end of the bed, that remains static. So your purpose as a doctor, explaining to the patient, and the easiest way, I might have 2 pillows only. So again you have to buy, তাহলে বালিশ কিনতে হবে. So don't. Okay. Now aortic coronary bypass operation. In aortic coronary bypass operation, great saphenous vein with some of the tributaries is removed with the arterial grafting. Due to presence of valves, vein has to be reversed and replace an arterial obstruction. Venesection of the saphenous vein. Venesection of saphenous vein, the saphenous nerve should not be included in the ligature. When you do a venesection, over here you make an incision and open the layers, and then you have to only put in the vein. When you are making a venesection, you have to do tags of your I have dissected now this portion. Over here, I take dissect out and take the vein like this, loop. You loop like this, take it like this. Okay. Then you make a small incision and put the tube. Where the word up? A tube. এটা ধরো ভেন, আমি ওপেন করেছি, ডিসেকশন করেছি, কিন্তু এটাকে লিফট আপ করতে হবে, ওইখানে যে সুচারটা তুমি, if you are putting in the suture, then don't include the nerve. Nowadays, of course, the KitKat, Gelco, many sophisticated cannulas are there. But in our days, at times even you might have to do a venesection. Even the big modern hospital, you have to do it. So, Trendelenburg's operation, incompetency of saphenofemoral valve throws great strain on the more distal valves and whole great saphenous vein become varicose. The great saphenous vein is detached from the femoral vein at its point of entry, and its tributaries in groin are ligated individually, otherwise varicosity will recur. This is a Trendelenburg's this thing. Here, normal one-way vein valves. See, normal one-way vein valve, blood flowing to the heart. Now, healthy valve prevents reverse blood flow. This is the healthy valve. Blood flowing to the heart. The reverse blood flow from due to damaged valves. So it's reversed. Varicose veins, normal one-way vein valves. Stripping of varicose veins. Stripping of varicose veins is done after identification of exact site of defective perforators or whole length of the great saphenous vein. a flexible wire is introduced in the vein from medial malleolus to groin, where it is brought out of the superficial vein after disconnecting it from the saphenofemoral junction. The wire stripper is pulled proximally and entire vein is avulsed. From the medial valve, you can see the valve, the vein. Now you put the stripper, you put through and make an incision here, and you just pull it out like this, that the whole thing comes out. That skill you have to develop, that expertise you have to develop. Now, yeah, here's the stripper. See, here's the stripper being removed. Stripper head attached to the end of the vein stripper. The calf incision where vein stripper and end and exist. Stripper head is attached. Ligated venous branches, and that stripping. So, you won't be doing it in your internship or house job or when you are SR. If you are in a cardiothoracic vascular surgeon, it is the vascular surgeons who are performing. Initial days, it was only general surgeon would do. A word gulo mone rakho, go home and short note. Please, Tonakas, because we are running short of time. Normal vein, varicose vein. Now you can see the one-way valve, pooling of blood, backflow. Enlarged greater circumference vein, direction of blood flow to the heart. Deep vein thrombosis. The blood flow is sluggish in soleal venous size when muscles are at rest. What I told you. After that operation and all is total rest, 3 hours, 4 hours that I operated on a filarial scrotum and penis. It took me 3 hours, 3.5 hours with skin graft. Naturally, as he was put in the ward, we started giving that exercise. Okay. Now, prolonged rest in bed, surgical operation in some patients develop deep vein thrombosis and can cause very severe complication, pulmonary embolism. You have done a fantastic operation. Ultimately, due to patient dies due to pulmonary embolism. That everything goes in vein, and you say the operation was successful, but patient is dead. Huh? That you can't write on your death certificate. Okay? Now, here you see the severe varicosity. Now, this is, you will get it even today, this type of leg, you keep on clicking. I told you, document your whole 5 years journey, 6 years journey. You document, you get some nerve or some vein, you take a picture, keep it, and put date and this thing, put it in a folder. What happens when you go pass out, ICMR scholarship or something is there, summer scholarship, 3 months. Your case report, you can go for a scholarship. Now, inguinal lymph nodes arranged in 2 groups, superficial inguinal nodes and deep inguinal nodes. See the different types. The green is the lymph nodes and lymphatic vessels. Superficial inguinal nodes situated in the subcutaneous fat and consist of upper and lower groups. Upper groups contain 5 or 6 nodes, forms a chain immediately below inguinal ligament. Lateral members of the upper group receive afferent lymphatics. Gluteal region adjoining anterior abdominal wall umbilicus. Superficial inguinal nodes, medial members of upper group receive lymphatics from subcutaneous tissues of the abdominal wall below umbilicus, penis including prepuce and scrotum in male, valve and vagina below the hymen in female, perineum and lower part of the anal canal and pectinate line, few uterine lymphatics which accompany round ligament of the uterus. Lymphatics from testes do not drain into the inguinal lymph node. Now, you please, this is very important. This is very important for a examination of this thing. And see, you see lymphatics from testes do not drain in inguinal lymph nodes. See, a patient comes, adult male with your big tumor on right side or left side, any side, see. First, in a male with this presentation, you look for the testicles, because undescended testes is a problem when the mother notices that one testis is missing. So if she comes at 6 months or 1 year, don't, oh, thik hoye jabe, don't do. You try to do a clinical test, you just you make the child cry, you pinch, just slight pinch, the baby. You try, intra-abdominal pressure increases, the testicles might be seen in the inguinal region or just above just above the scrotum. Then you can see again it can be a retractile testis. But you, in this situation, you have to ask that every initial stage is every 3 months to just come and visit and show you if this is progressing or not. And after then every birthday up to 6 years. And now you are having your ultrasound, pediatric sonologist, you send to any radiological center and see if it is abdominally located. Maharaja palace mein tha during embryogenesis, and the red carpet is laid and it descends and descends and goes to the scrotum. With the red carpet means the peritoneal gubernaculum testis. This is one thing you have to note, that and then the abdominal tumor at age of 20 or 18 or 16, if there is a testicles is missing, it's a danger. It can be a seminoma of testes or any testicular tumors. So you have to immediately go for consult with the radiology oncologist and take an FNAC. When you see this type of tumors in male, please do an ultrasound. You please do an CT abdomen and you please do an FNAC. You have to know the importance. See, one thing is that sometimes the lymph nodes in children even, it becomes enlarged. It can be, the lower abdomen, there might be some impetigo or some skin infection or some inflammation. Then this part drains into the superficial inguinal lymph nodes. Then you palpate and feel, try to feel and see exactly what is the pathology. Don't say, oh, thik ache, thik hoye jabe. Don't take casual, because any small lesion like a lymph node swelling, the mother gets panicky. Even if you see lymph nodes in the neck, you are giving vaccination, BCG. Naturally, there are chances that they won't have a tuberculosis. But I told you the other day, tuberculosis can be, or most common, impetigo of the scalp. It's a skin infection. Or an abscess that drains into this thing. Then you please look for the child's scalp and head. Or you ask the mother that did he have some infection? Have Babu? You sure that it's an inflammatory drainage into the chain of lymph nodes. It can be of any any location of the human body. You can see if your left cervical gland over here, any gland, the big this thing, Warshaw's gland, that is owing to the gastric carcinoma. Now, deep inguinal lymph nodes vary 1 to 3 in number and medial side of the femoral vein. Now, 3 are present in the lowest one is situated below the junction of the great saphenous vein. The middle in the femoral canal gland of Kluckert. This can be MCQ or a short note. So over here the femoral here the lymph node here. This is the this word gland of Kluckert. Now, deep inguinal lymph nodes, afferent vessels received by deep nodes are derived from deep lymph vessels with accompanying vessels. Now, glans penis or clitoris, few efferent vessels from superficial inguinal lymph nodes and deep efferent from deep inguinal lymph nodes drain into the external iliac nodes and are piercing the femoral septum and closes the femoral ring. Now, you see this glans penis and or glans clitoris. Now, that sometimes present as a malignant glans. Now, you please see and observe accordingly, see the lymph nodes, feel the lymph nodes, and if it is a carcinoma of the penis, it does not spread. It will later cases. I have seen even this much of size of table tennis ball, ping pong ball. I have seen. Now, that is a very, today I am telling you 30 years, 35 years, 40 years ago, there was no ultrasound to screen. Now, you see the ultrasound, you see for any enlarged lymph nodes, where are the groups of lymph nodes, of the external iliac group of lymph nodes, there is a spread. But you can give one thing, the objective of an operation or your treatment, I would say rather treatment. Now, the treatment is, of course, you go for an anesthesia, spinal anesthesia, but you can operate your penile carcinoma with a local anesthesia. You have to just infiltrate here, you have to infiltrate in the penis, and then you tie a tourniquet here and you make an incision and remove this part. Now, over here, the skin flap, you take it, put your Foley's catheter and you make this thing and suture. You relieve that person. I have done some operations of this type of. Now, those patients are still living. 35 years, 25 years they are living. Okay, you don't want to touch, you don't want to operate on, you want to send a super specialist, then you have to diagnose. Make a prescription in any form by clinical diagnosis and also your itna phadda, ekdam shopping mall ka phad do. Reliance store. It goes on, it goes on. So, why I'm telling you, you become a good MBBS. You diagnose কে পাঠিয়েছে? ও শর্মিষ্ঠা পাঠিয়েছে। আরে আমার তো কিছু করার নেই। I have nothing to do. I have to operate only. One of my teachers, mentor, who I did 3 months of gynecology as an intern, and Professor Ghosh, Anil Ghosh, he was one of the, in those days, he was a champion scholar in gynecology and obstetrics. So, whatever I learned, many things are from him. He used to tell me, before sending a patient, you investigate what you want to. So, I have nothing to put in extra. Then what they will have, the patient party and patient will have the confidence that you are competent enough to guide. The patient will again come back to you. Okay,